Welcome to another episode of the PFC podcast. The opinions you hear are ours and doesn't necessarily reflect anyone else's. Now on to the podcast.
Hi, welcome back to the PFC podcast. And today I thought what I would do is a little kind of a look ahead type podcast. And I think nothing is kind of on the forefront of what could be in prolonged field care and austere medicine than the REBOA. I think I've heard about it talked in just about every conversation that has to do with massive hemorrhage. So I thought there'd be really no one else that would be a better person to interview than the originator of this, for us anyway, this idea, and that is Dr. Joe Dubose.
Yep, thanks for having me, Dennis.
It's my pleasure. So just kind of going into it, what I would like to know is what are your thoughts on, in the future, 5 years, 10 years maybe, do you believe that, specially trained non-physician providers will be using REBOA in an austere environment, even though they don't have a definitive surgical capability, nor really the ability to confirm placement?
I do think this technology has a lot of promise, particularly for control of hemorrhage from non-compressible sources that really represent a challenge on the battlefield, and for that matter, when patients get to the MTFs, medical treatment facilities. I think it's a two-part question here that you're asking. One is the first is actually three-part. The first is, can specially trained non-physician providers perform REBOA? And I think the answer to that is definitively yes, with the appropriate training, both on the front end and maintaining currency, which is I think one of the bigger challenges moving forward. The other element of this question was in an area without definitive surgical capability. I think that you have to be close to surgical capability, that REBOA is really just an extender of time that you can have to get the patient to definitive surgical damage control surgery capability. So it's really going to be those patients that are within range but would not otherwise survive unless we can extend that period of survivability until they can reach damage control. If that period is 12 hours, I don't think REBOA, as I envision it, is going to be something that's going to be very useful in the future. And the last point about the ability to confirm placement without imagery, I think that is already a capability that is in our hands. That certainly is the most common scenario that is utilized at level 1 trauma centers in the U.S. or at medical treatment facilities in the deployed environment where this is used. We've learned now that with the current devices, and those are going to continue to evolve, that we can safely place these without confirmation with imaging.
I think the advances in ultrasound have kind of blown everybody's minds as far as what could be possible as far as imagery goes, and the ability for really anybody that understands what they're seeing, how to diagnose and treat of injury of some kind.
Absolutely.
I think if you don't mind, I want to kind of go back through those three answers. So about the specially trained non-providers. Now, usually, at least in the conversations I have, this topic is pretty polarized. Either it's absolutely they're going to be doing it, and people are already thinking of ways to improvise. I've heard people talk about, well, I'm going to use a Foley catheter as an improvised REBOA. Then you have the other side that is like, hell no, no way on this green earth is any non-surgeon or non-physician going to be doing this. I don't really think, for at least those people, that the act of putting in the catheter is necessarily the issue. I think it's all the kind of ancillary parts to it of knowing what is the right patient, what is absolutely the wrong patient, and kind of that aftercare component to it. What do you think?
No, I absolutely agree with you. And as with all things, the truth lies between the extremes of opinion somewhere. But I completely agree with you that this is not a procedure that needs to be improvised in any way, shape, or form in the hospital or in the pre-hospital environment. We've got now devices that are better suited to utilization in the early phases after injury. And I think those are the devices that you're going to see pushed forward. Some of the big challenges with this are not so much the placement, physical placement of the device, but the access, the femoral access, which is, even as a trauma surgeon, I don't do many common femoral artery cut downs, or I didn't until I started utilizing REBOA as an active part of my practice. And that's not a skill set that a lot of people are comfortable with, and you can cause some significant damage doing. Now, I think the ultrasound guidance makes sense. It improves the safety profile. And a lot of the medics are already familiar with that technology. They can do an EFAST. They can do ultrasound localization for regional blocks. I think it'd be a simple matter of training them to identify the right segment of the femoral artery for placement of this. And that's something that we could do, and we now teach non-surgeons to do in some of our military training platforms. The challenge will be, how do we keep those people current? This is not a skill set that is particularly forgiving if you learn it once and then you go out and don't get recurrent training for 3 years, or never look at a human common femoral artery ultrasound guided access again. So how do we maintain that currency for these advanced medics that are going to be downrange? And that's one of the things that we're struggling on the provider end with how to establish. Because I do think that's an important part when people come back off deployment, come back into their training cycles. How can we better incorporate real meaningful clinical experiences where they can continue to hone their medical skills and then utilize them when they go back into the deployed environment?
Oh, absolutely. I think even the bigger picture, I think that's another area that we need to get a lot of research in, is how fast is the degradation of not only just tactile skill, but just maybe clinical knowledge when you've been taken outside of an environment for a period of time. How fast does it degrade, and how do you intervene at the appropriate times to maintain a skill set, so when somebody does go back downrange, they're at least close to optimal as possible.
Yeah, absolutely. And the other big thing with REBOA is at present, it extends your interval for getting that patient to damage control surgery to address that non-compressible hemorrhage source, but it only extends it by about 60 minutes at best. Beyond that, you're not going to have a survivable patient. So we need to be thoughtful in our algorithms, whether it's pre-hospital medical provider surgeons and ER doctors, or whether it's pre-hospital advanced medics, to incorporate those into decision processes and algorithms that, a permit for, really that short window of duration. Just get that patient who otherwise would not have survived to reach the MTF there. But there is that hour-long time frame at present, as best as we can estimate. And it's going to be different for every patient. But beyond an hour is really not going to be a very survivable duration to have complete ischemia below the balloon.
Right now, in the Special Forces Medical Sergeant course, in some of their rotations, they're getting experience using shunts and stents. Do you think that type of skill is realistic to have like an 18 Delta, working inside the box downrange?
Well, I think our 18 Deltas are trained to be the best at what they do and deal with very challenging circumstances. And that's what the instructors in this courses teach. I think shunt utilization makes sense to me. Again, I see some challenges with maintaining the currency with that skill set. I'm a double-boarded trauma and vascular surgeon. I can tell you putting a shunt in an austere environment is challenging for me. And I think that, we may find that it's also going to be challenging for some of the medics, but that makes sense to me from the standpoint that you're restoring perfusion to a limb and getting blood flow downrange. So if that can be done effectively, I think that's a very worthwhile skill set to explore in a thoughtful manner. Stents with this it'd be more challenging for me to figure out how that would be integrated. It'd be neat to see how they're teaching that piece, but both of those modalities are designed to restore flow. So you're extending the life of that limb for a much longer period. When we talk about things like whether it's as simple as a hemostat on the femoral artery, or tourniquet in place. I mean, this is essentially an internal tourniquet if you want to think about it that way.
Mm-hmm.
We're now inducing ischemia, and that we can keep the patient alive, but that payback after a lengthy period of time is going to hurt us by the time they get to that MTF.
And I mean, restoring that perfusion is going to be key. I think it'd be no different than crush syndrome, but in this case, it's going to be the lower half of his body from the diaphragm down, for zone 1 anyway.
Yep.
On to the next area. So for some, let's say that they decide, we're going to start training on REBOA. What are the skills necessary to be able to actually place this catheter and then ultimately maintain this patient?
Well, the technology has improved quite a bit. When we started utilizing REBOA, it was with a number of devices that were more commonly used in endovascular surgery, long wires and a coda balloon and things that were challenging in the hospital environment, much less even discussing them in the pre-hospital environment. But some of the newer devices, most notably of late, the Prytime ER REBOA, and I'm not affiliated with that company in any way, shape, or form, but the design that they utilize came out of military-specific demands and some interactions with Air Force researchers at the Air Force Clinical Research Lab in San Antonio. This was 10 years ago that they started talking about this stuff. And the design has really brought this skill, I think, within reach of a much wider group of people. The real challenge, I think, with the new device is actually getting the access to place it. And common femoral artery access can be challenging in the best of environments. If you have ultrasound skill set and capability and the patient still has a pulse and you can visualize the artery, then that certainly makes it easier. And for that reason, I think a lot of people in the clinical setting are now moving towards, but when they get to the MTF, if they're unstable, immediately going to common femoral artery access so that they have the option to then upsize that and place a REBOA. How we do that in the field, I think ultrasound makes sense. And I think that you're going to see that this will become a procedure where ideally you would use ultrasound. In our registries capturing REBOA use in the hospitals, still about 50% of these patients need a cut down because they've reached a point where they don't have a pulse or the ultrasound is not available. And so what we see is we continue on the surgical side to have to train surgeons how to do common femoral artery cut down and expose the artery. And so that's not a skill set that we teach to many folks, and even trauma surgeons are not particularly facile with it until they get adequate training to do so. So that represents a challenge, and I think a hurdle that we'll have to clear to make this a reality for the advanced medics in the field.
But after you've in place the REBOA catheter, does my resuscitation change? Does my ventilations, do those have to change at all?
Ventilation is typically not going to be as big a problem. I think resuscitation, the key to understanding the balloon once it's up is you'll see in a patient who responds, many of them respond quite well. And so you start to feel good and comfortable for a few moments. But what you have to understand is that patient's got to be moving somewhere to get to definitive surgical capability. And you've got to continue your resuscitation even if the vitals look promising, because you've got now this reperfusion injury that you're going to have to pay back at some point. Mm-hmm. So resuscitation should continue in the fashion that we teach in TCCC and that you teach in the schoolhouse. Optimally whole blood products, if you have it available, or balanced resuscitation. But you can't back off of resuscitation when you put the balloon in, because you're building that ischemic burden distally that's going to be washed out when you let the balloon down. And if you don't have the patient well resuscitated, it's basically, they will expire the minute you let the balloon down.
Speaking of letting the balloon down, I read in your interview with MCRIT, you had mentioned leaving the balloon up for a period of time and then slowly letting the balloon down. Do you think an application like that, or there would be any kind of application of either very slowly letting the balloon down or periodically letting the balloon down to test the clot formation or test that you have hemostatic control has any kind of application in kind of the austere environment? Or would it be, do you see it more being you inflate it, you inflate the balloon, and then you got 60 minutes from time now to get him to a surgeon?
I think the concept you're talking about, which we've called partial REBOA or P-REBOA,
Okay.
is another way to extend the utilization of REBOA for a little bit longer. And just for the listeners, essentially what that entails is putting the balloon completely occlusive for 10 minutes, allowing some clot to form distally where you want it to form, and then letting the balloon down just enough so that you get flow around the balloon to restore perfusion to the intestines and all the organ systems below the balloon, but not enough pressure to knock that clot off and cause additional hemorrhage. Not every patient is going to tolerate that, but in the patients who do, we can minimize the amount of ischemic burden that we have to pay back later below the balloon. It's basically normotensive resuscitation above the balloon, and then below that old concept of hypotensive resuscitation that many of the listeners have probably are familiar with.
Right.
So it's a balance. It is something that we're trying to teach our providers in the hospital, and I think as we continue to refine that technique, it's going to show additional promise. It's something that I use every time when I do a REBOA, and I think it's probably the way forward for regardless of environment that we utilize it in.
How would you like to see training progress as far as ultimately getting REBOA into the field? Like what skills would need to happen first? What kind of courses would need to be set up in order to ultimately get this into the field and utilized effectively downrange?
Well, I think on the front end, we have to have some, whether you want to call it introduction or familiarization training, and teach people the steps that are involved. We do that on the surgical side. We do that through the American College of Surgeons has a course called the BEST course, or Basic Endovascular Skills for Trauma course. And it's essentially a REBOA course. So we talk to people about what REBOA is, what it isn't, how it can be done safely, and all the pitfalls that you can encounter and strategies to mitigate those risks. Beyond teaching people that, and again, that is a didactics, that's cadaver-based utilization, and some simulation-based utilization. It's a one-day course. We're talking about extending that a little bit longer for ER providers and providers who are not surgeons to try to encompass more of the familiarization with the endovascular concepts. But you got to have some front side training. And the big thing for me, I think, is going to be the currency training. How do we keep people current? Okay, so we can teach medics, and I think we can, how to access the common femoral artery, which to me is the biggest challenge with REBOA utilization, besides figuring out how long I can leave the balloon up and the judgment of what scenarios to use it in, patient selection. But how do we keep them current? How frequently do they have to come back for refresher training? And ideally, how do we get that patient into a trauma center, that medic into a trauma center on a Saturday night so they can get experience in the civilian world in a controlled setting, so that when they're out on the uncontrolled setting of the battlefield or that Role 1 casualty collection point, that they have that familiarity, that reflex, if you will, on how to utilize this most effectively.
Speaking of getting experience, how many hospitals are using REBOA, at least in the United States? I've heard of Baltimore Shock Trauma doing it. I believe where you work was it UNC Berkeley?
UC Davis.
UC Davis, sorry. But I haven't heard of lots of other hospitals doing it. Is it very common across the board?
There's about 18 centers that contribute to our registry. This is a very hot topic in the trauma surgery world. It's also polarizing in the trauma surgery world, even amongst the surgeons in use in the hospital. But I know from the discussions with the company, Prytime, they have at least 100 hospitals that have ordered these for their shelves. Now, not all those are being applied purely for trauma indications. Another indication that people are using this for, as a side note here, is women with placenta previa or post-obstetrical bleeding risk.
Right.
this has been employed quite effectively, actually, in a lot of the management algorithms for those women who bleed after childbirth excessively. So that's another region where people are gaining some familiarity with this.
So other than actual placement of the catheter, what other skills or understanding do you think providers need to have in order to do this safely?
I would tell the medics the same thing I would tell the surgeons who place this is the tendency when you see somebody's blood pressure or vitals improve with the use of REBOA is to want to pat yourself on the back. And I would say the work's really only begun when you get to REBOA. Sure, in a patient who was completely decompensating and about to expire, you've now restored perfusion to their heart and brain and extended their survivability. But you got to continue to resuscitate them for the injury that they have, which is a non-compressible hemorrhage. And you've got to get them somewhere where you can get definitive control of that. And those are the real challenges. It's not the REBOA placement is much like an ED thoracotomy. You don't put a clamp on an aorta and then sit and pat yourself on the back and have a cup of coffee. You got to continue to resuscitate and get somewhere as quickly as you can to address definitively the hemorrhagic sources.
Understood. This is, I guess, more for myself. So I can see where that 1 hour would definitely be a problem in a prolonged field care scenario. I think the next step for this may be ECMO to extend out the heart and the brain ischemia. What are your thoughts on this? Because it really seems like from REBOA to ECMO is just a skip and a jump.
Yeah, I completely agree with you. I think in the future, we're going to see devices and approaches that tie all of these things together. So you've got a balloon that goes up and occludes for a short period of time. And then you can, in a controlled fashion, restore perfusion below the balloon into the injury bed. And I think there's also some opportunity there are a lot of pharmacologic adjuncts that have been looked at in the research world. Valproic acid comes to mind as one that give patients that basically prolong their ischemic tolerance. So it sends the cells into a state where they can tolerate that ischemia a little bit longer. So how do all these tie together with a balloon occlusion, pharmacologic intervention to prolong ischemic toleration, transitioning to ECMO? I would say that I know there are people working on devices that move seamlessly through that paradigm. And I think that in the next 5 to 10 years is where you're going to see some very interesting innovation take place.
Is there anything else that I may have missed that you'd like to talk about?
I think, the debate about whether or not we should be doing this in the pre-hospital environment is an important one. And we do have some limitations with the present devices, but the devices are going to continue to improve. And I think the best thing that we can do now to prepare ourselves for the future is to integrate the medics into the utilization of these new technologies as much as possible. If you're part of the team, some of the small surgical teams, when we're in the deployed environment, the medic comes in with the casualty and is often there at the roll 2 or with an austere surgical team where these things are being utilized. And I think it's important that if we train them and familiarize them with the technology, that they become a valuable part of the team as they roll in the facility with that casualty. And the more we can do to kind of educate folks about what REBOA is, what its present limitations are, what its promises for tomorrow may be, the better we are positioned to integrate this and utilize it in the pre-hospital environment when we get to that stage. So I just encourage the listeners to learn about it. If they're in an environment where they can go to their trauma center or their ER and actually participate in the care of these patients, that's going to be a useful thing moving forward.
Absolutely. More experience, more training is always better. With that, I'd like to thank you, Joe, for taking the time to talk to us about this.
Absolutely. Thank you so much.
All right.
Hey, this is Dennis. As a quick admin note, start getting your abstracts into SOMA now. SOMA 18 is coming up. It's going to be the 30th anniversary. It's going to be huge. But as soon as the holidays come around, you're not going to do it. So start working on that stuff now and get it submitted beforehand. Start influencing the landscape of combat medicine. That's another one for the books. Make sure to go to the site, www.prolongedfieldcare.org. Post your questions, post your comments, make your voice heard. This is Dennis for the PFC Podcast, out.